Good evening, everyone. So, hope I'm audible to everyone. So, I'll be talking on this seventh update on COVID. So, I've already covered the past journal articles in last six updates. So, this time I would be talking about the three articles. I think, as you would see, there is a lot of noise coming from various journal articles. So, it is extremely important to identify what is most pertinent for us to discuss. So the backdrop of the article I picked up is this particular WhatsApp picture that came to see the allocation of resources that has happened. So this is you see the doctor here who is not having protective equipment personal. So he's putting a handkerchief without a glove. But you see the other people, the security and the VIPs having glove and a N95 mask and others. So it is extremely important, friends, that we need to clearly understand what allocation of resources mean. So I picked up this journal, which is very important now, considering that there is going to be a lot more cases that will be coming to the hospitals and to the ICU. So this came in NEJM, as you see, on 23rd March 2020. It's a fair allocation of scarce medical resources in the time of COVID. So what is important is to know the historic background. So historically, it is shown that during epidemics, there needs to be rationing of certain medical services that we offer and the interventions that we provide to the patients. So if you look at the US, so they are already claiming there is shortage of N95 masks, and they are contemplating on reusing the N95 mask, and they're looking at strategies to reuse N95 masks. And in Italy, they are prioritizing the allocation of ICU beds and the ventilator to the patients who would benefit most from these resources. So already this allocation strategy has started in countries where there is explosion of cases. And in UK, they have a strategy of downgrading personal protective equipment, so which has been heavily criticized by the various authorities. So this whole article looks into how we can, ration these medical resources and how it can be accommodated fairly. So they come out with six recommendations. It is important for every doctor listening to this to understand how we rationalize our resource allocation. I think that is what this whole article talks on. So I would urge all the healthcare administrators to read this article. So if you look at the difference between the influenza and COVID in the US data, so you see the red box. So you would see when moderate COVID strikes, I think the number of patients that would be admitted to ICU would be staggering 960,000 people, around close to 10 lakhs. And if it is a severe COVID, the number of ICU admissions would be 3.8 million. So this is the projected figures in US, which is an alarming number. And if you look at the number of deaths in US with if the COVID strikes them severely, it will be close to 2 million. So which is really, really worrying trends and the projected trends that they have described in this NEJM article. And we have seen this figure multiple platforms that there is one patient if who has a potential to infect 2 to 2.5 people. And when that happens, so you have this reproductive number. So in 30 days, around 406 people would be infected. So if you extrapolate, so around 5% of the population could get affected in 3 months. So that is the alarming rate at which one individual, if he is allowed to infect, he can literally lead to 5% of the population getting affected and multiple people participate in spreading this infection. So that is why it is extremely important as to why this quarantining that has been adopted in our country is terribly important at this point of time. And let us so this NEJM article does look into the Chinese data. So when we look at Chinese data, what is very clear is 80% of the COVID-19 patients are asymptomatic, or they do have very mild symptoms. They're ambulatory. They don't need ICU hospital admissions. So that is a good number for us to have in back of mind, which means 80% when they stay at home quarantined. So we have a good ability of them not spreading the infection in the community. And the advanced healthcare services, which means the hospital care is needed only in 20% of the patients, and 15% of them will have severe illness, and 5% is what the figure we would be looking at in worldwide who would need critically ill beds. But this data is little different to Italy, because Italy it's more than 10% are needing ICU. But I think we can subscribe to this figure in our country. Only 5% would need critical illness. So the mortality from the Chinese data is 0.25 to 3%. and it is shown to be higher in elderly people, and where mortality can be more than 14%, or patients with a lot of comorbid problems. So 10% of cardiovascular disease and 7% with comorbid of diabetes had a higher mortality. And it is clearly shown that the mortality is in COVID is higher than seasonal flu, where seasonal flu mortality is only 0.1%. So this is the backdrop as to what is the number of cases that would possibly need our ICU admission. So it's around 5% is what, if you look at it. So this they have extrapolated to the American data. So the American Hospital Association, so they have looked into their own country database, and they realized that they have 85,000 ICU beds, and they have 62,000 full featured ventilators, and they have 98,000 non full featured. But what they have realized is what is extremely important is the manpower, because to operate these ventilators you need skilled doctors, respiratory therapists, and nurses 24 hours 365 days, which means in 3 shifts you would need this sort of a manpower. And remember, when COVID-19 strikes, some of these nurses and some of these doctors may be quarantined, or they may get ill and they may absent themselves. So there would be a tremendous sort of a pressure on optimizing our manpower or to operate these ventilators, which is a serious concern. And American Hospital Association, they realized that there would be an impending shortfall of personal protective equipment in any sort of a pandemic or epidemic the type we are dealing with. So this is something which every country should be geared for, and that's what I think in India we are doing. So every hospital, every state, they are putting enormous resources to try and optimize this stacking up of personal protective equipment so that we don't fall short. And most importantly, amidst all this, Anup has spoken about all these good drugs, hydroxychloroquine, lopinavir, favipiravir. See, again, when our disease explosion happens and when there are more sicker, like 15% get admitted to hospital, the requirement for this drug also starts increasing. So there will be a cascading increase in the requirement of these drugs, and production of these drugs also does take time, and that may also impair our optimization. So I think the whole strategy, even this NEJM paper talks, is we need to adopt very stringent public health measures so that we buy time, so that we have good lag time to do all these preparations, to optimize ventilators, to optimize ICU beds, to optimize personal protective equipment, to optimize the drug reserves. The public health measures have to be adopted in every country, and I think that's why our honorable government in India has adopted this. So basically, adopting this basic innate public, keeping safe distance, washing hands, working remotely, avoiding crowds, stay at home like we are doing a webinar, no handshakes, and cough etiquette. And even there is a new data coming from different countries saying wearing mask. I think I find extremely good. I have to applaud our Karnataka police and government who are enforcing that everyone wears a mask, which is very important, because it is being realized that the burden of this disease can be minimized by simply wearing a mask whoever ventures out of the home. So this also is a simple steps which has shown remarkable difference. So like there was a report from Czechoslovakia where they found, Czech Republic, where they found significantly reduced. They could flatten the curve by just using masks wherever they went. I think what this all enables us is enables us to give adequate time for us to prepare ourselves. Even when the curve flattens, we start getting a lot of cases, there will be adequate preparation in place. And I'm sure every listener on this forum knows that they are preparing at their best to make sure that they have put all the processes in their place. I'm sure no one in India is sitting quiet. Everyone is putting in their best efforts to prepare themselves for these cases, which may start swelling over the course of time, is what we are foreseeing. But our prayers remain that it doesn't swell as much as it has in other countries. So what are the recommendations this paper makes? So obviously, whatever recommendations that we make on rationing the services should encompass ethical principles, isn't it? So the first one they say is our intent should be to save maximum lives and improve the prognosis. So that receives the highest priority. And another thing they say is when you have two patients with a similar prognosis that come in, so we need to use this random selection, which again one can debate and argue. So they sort of desist from saying first come first served should not be the way to go. So this is extremely important. I think this particular thing I want all listeners to pay attention. So this article emphasizes, even from ethical standpoint, priority should be given to the patients who have significant contribution to the society, and that should be rewarded. They call it as an instrumental value, and all healthcare personnel fall under the category of this, where they are of huge instrumental value. And if you see the underlining I have done, you have to give priority to the healthcare workers if you have to choose between 2 3 patients, and this comes from the ethical standpoint from this paper. So that is something which is good for us to impart to all the people around the administrator, especially in any sector, so that healthcare workers are given priority when care has to be delivered, when hospital care has to be given or ICU care has to be delivered. So this message is important for every intensivist who is logged in today, that priority has to be given to healthcare personnel over anyone else when they come sick to our ICU with possible COVID. I think that is a good message that you get from this paper. And obviously, we choose young patients who have a good ability to recover over the elderly patients. So they have come out with these 6 recommendations. The first recommendation is they call something as resource stewardship, which means our intent should be to save more lives, but more lives with good quality so that they are productive. So maximum length of life is what should be, and we should encourage during this course of time an advanced directive. So if you have an elderly individual with a lot of comorbidities, with end stage organ dysfunction, who may not really have a good chance of recovery, so we should work towards having an advanced directive for such patients, or if they have an expressed wish, we should adopt it. And we should emphasize on patients who are likely to recover than a patient where we know for sure that whatever measures we put in place, their recovery would be very unlikely. And withdrawal in a patient where multi-organ failure has set in, where continuing ongoing measures would be futile. I think withdrawal is something that we should be adopting. I know that it is all a debatable issues in India, but I think it's a good paper to have some clarity on all these aspects to optimize resources. So the second recommendations the authors make is the intervention. So when the 5% of the population who may need these advanced interventions like ICU beds, ventilation, testing, again clearly recommendation 2 says that we have to give absolute priority to the healthcare personnel, be it doctors, be it nurses, be it respiratory therapists, and they are considered as people with instrumental value during these epidemics or pandemics. And this will also encourage, if their healthcare is well protected, and you would be optimizing your healthcare pool so that the care to the patients will be optimal, and it can be better optimized. Because if you're not caring for them, they become more sicker, then obviously you'll have issues with absenteeism, and you have less healthcare personnel who can deal with the sicker patients. So I think this is the point. I think from this paper, I really need to emphasize that priority across the board. It doesn't matter if it's corporate hospital. So across the board, government, all hospitals who are dealing, I think the priority has to be reserved for this, because that is ethics, and that is conforming to the ethical principle. So the recommendation 3 is, if you have 2 patients coming with COVID with similar prognosis, this paper suggests that random allocation of some sort of and they even suggest it could be a lottery sort of a random, and they do desist from giving preference to first come first served. I know you can debate on this. The reason they say that is, if you adopt this first come first served, then even the less sicker patients would rush in and claim that they need admissions, as opposed to the another patient who may be delaying his presentation. So I think we wouldn't go too much, because I don't know how much would that be applicable in our country. So the fourth recommendation is they talk about prioritizing guidelines, which means the guidelines are fluidic. So they suggest that guidelines are not rigid. So as I said, these guidelines are evolving. So even these guidelines has to respond to the changing scientific evidence. See, every day, I think there's so much of noise, so much of literature coming from on this COVID. It is extremely hard for us to rationalize what is right thing, what we think is right thing today may not be the right thing after a week, because the evidence is so rapidly changing, and the type of experience also is fairly different from the China and from the Italy and from the Spain or USA. So things are very different. So our guidelines also have to be fluidic, and they should change with changing scientific evidence. And in recommendation 4, they say, they give an example. Suppose if a vaccine comes out, the suggestion is preference has to be given to elderly, because vaccine is more preventative. And the argument they make is the younger individuals have a better ability to develop herd immunity, and that may be more protective. Unless you have shown epidemiological modeling saying that vaccine has to be given in younger people to prevent the spread, then it's a different issue. So these are all little nebulous points, but as authors keep giving examples to justify that why vaccine should be preference should be given to elderly. And recommendation 5, I think this is also important. If any of the patient is enrolled in a trial, suppose ICMR is doing a hydroxychloroquine trial, and if a patient is enrolled, and he should be given preference for all the services, and because he becomes instrumental value. So any patient who is involved in the safety and efficacy of the vaccine or the drug trials or participates in any research that a organization or ICMR is undertaking, so that patient will be given preference. So this is also a very important point for listeners to bear in mind. And another, this is the last recommendation, which is very important. So again, in the zeal and in our overzealous enthusiasm to treat COVID-19 patients, we cannot forget the other patients. So I think there is no difference when we are trying to stratify. The ethical principle still remains that which patient maximizes or has an immense benefit from the interventions that you do is the one who should be given preference. So the example the authors give for this recommendation 6 is, if you have a COVID-19 young patient sitting in the hospital, sitting in a ER, and you have a young healthcare personnel coming with an anaphylaxis to an allergen, so the preference has to be given to an anaphylaxis, because definitely the chances of improving and survival is much better, and the instrumental value of that individual is more. So these principles are something that they suggest that we need to adopt. So the conclusions this paper makes is, the first statement the paper makes is, yes, government should take all measures to prevent scarcity of any of these medical equipments and medical interventions that we need to adopt. I think our Indian government is doing fantastic in that they are really mobilizing all the personal protective equipment. They are preparing COVID hospitals across India. I think these are all fantastic steps which exactly resonates what is coming out from the paper. And if we fall short, even despite all this preparation that nature has blessed our country with at this point of time, we still fall short and we have scarcity, then we need to adopt this recommendation. Based on these 6 recommendations, we need to come out with guidelines and adopt these guidelines. So that is the gist of this paper. So again, the 2 points I want listeners to have absolute clarity is that there is a good ethical sort of a substantiation that preference has to be given to all our healthcare personnel if they become sick. That is one. And second thing is, I think you have to rationalize as to which patient would benefit from the care that you are giving, and adopt and care for that patient, rather than taking care of another patient where that the chances of his survival would be poor. So I think those are the rough sort of conclusions that we can make from this paper. I think this picture typically denotes what has been happening in our country. Like, we are all really fighting to, fighting for our country against this wretched virus. But there are obviously some elements which have created certain obstacles for us. So we need to forget all that, and we need to continue to strive to fight against this virus. So I think I'll just take another 5 minutes to very quickly talk about this small little paper. This came in Lancet. I think this is also very important, again touching on the basics of what we should be doing. See, this also talks about the percentage. It talks about essential care of critical illness must not be forgotten in the COVID. So this is a very good one page article. So again, they say 80% they do not need hospital care, so you can forget. So this quarantine and social distancing should take care of this 80%. But what we will be dealing in our hospitals is this 15% and this 5%, right? So this paper emphasizes on caring well for these 15%, so that they don't spill over in our 5% and overburden our resource burdening ICU. So this is what this paper recognizes. And the example they gave is, I think they relate to Malawi, where 89% of the hypoxic patients with saturation less than 90% were not given oxygen, and 53% with low GCS were not put in supine or no airway. So what authors are trying to resonate is, simple steps can prevent this 15% spilling over to ICU. So this paper is all about what are the simple steps that we can take. So the emphasis is on low cost essential care. The simple things you can do is keep your hospital ready for any potential, which I'm sure all the listeners are putting immense efforts in preparing your hospital to be ready to tackle this menace. And adopt your strategies of good quality clinical practice in identifying, having a high index of suspicion in identifying patients with COVID, and giving good clinical care for these patients. And the second most important emphasis, which is low cost, which does not involve a lot of cost, is having an effective triage system within your setup. I think I'm sure every listener here would have strategized some sort of a triaging in their own hospital. And third most important, which I'm sure all our WhatsApp forums is filled with this, how to stack up or how to optimize our personal protective equipment gear. And our topmost priority is to ensure absolute safety of our healthcare personnel by having all the personal protective equipment. I'm sure every doctor, as I see in every forum, is putting in their best efforts to make sure that they have enough of personal protective equipment. And so does our government, because when you see a press release of from our honorable health secretary, every time there is a mention that they are putting a lot of efforts to get PPEs from indigenously manufactured here and from outside as well. And the simple thing what every hospital can do is have their own protocol which is user friendly and concise, which suits their state or their area where they would work. So have a simple user friendly protocol which is percolated and disseminated to all the healthcare personnel dealing with COVID. And and I think there is a good emphasis. I'm sure many of my Bangalore friends who have worked to, have given inputs to the government would agree with me that a lot of importance has to be given for oxygen, simple oxygen, because that 15% of the patients, low essential care, they only need oxygen, and there should be an uninterrupted supply of oxygen, and that should be optimized, is what this paper emphasizes. And this paper emphasizes on simple measures like if you have a COVID who is hospitalized, please maintain simple head end elevation or propped up position, good suction and good chest physio. These are simple, low cost, essential care the authors subscribe to, as which can have a huge influence on reducing mortality. Most importantly, to prevent these patients to heading into other organ dysfunction. And all together, our intent is to reduce the burden on our ICU capacity. Simple things: have uninterrupted, have this triaging, have hospital readiness, good protective, personal protective equipment, and uninterrupted oxygen supply, and simple fast hug principles which every intensivist know, and try to see how effectively we can minimize their spilling over to ICU. So that's all about this particular paper. Very simple, but very strong message that our whole aim is to identify this 15% and prevent them from spilling over into our ICU. And I think this is the flow chart that they talk. It's again the summary of whatever I said. So correct use of oxygen, triage system, oxygen source. So all this has a bearing on survival of the patients. And I think this is a very, just a single slide. It is from Dr. Devadasan from India. This is floated in WhatsApp. It's an excellent analysis, epidemiological analysis of how India is heading. So if you look from day 1 to day 28, if you see the curves in the Western countries like Italy, Spain, France, UK or USA, these curves are really exponentially taken off after say after 2 weeks. So if you see, so they have identified a factor. So Indian rise, if you see, Indian increase has happened with a factor of 1.45, but if you look at Italy, it happened with a factor of 198, which means we are really winning this at this point of time. The steps taken collectively by our medical community, by Honorable Government of India, has been fabulous at this point of time, because our increase has definitely stupendously better compared to these countries. But we don't know still, we may still have a issue with this curve taking off, and as you see, it is slowly raising its hood. So I think we need to take all the efforts to make sure that this doesn't happen. Okay, and I think this is only two slide study, very small article which came from Gattinoni. It came in American Journal of Respiratory on 30th March 2020. Basically, this Gattinoni, I'm sure every intensivist hearing to this webinar would know who Gattinoni has put a lot of work on ARDS and lungs. So he did a small observations in 16 patients, and he found that the COVID-19 ARDS is very distinctly different to the conventional ARDS that we have been dealing with. I think this is also, we have extensively discussed in various platforms. So what he found is respiratory compliance of these patients is somehow found to be very good. It's 50.2 plus minus 14.3, which is a good compliance, in unlike ARDS where you would expect a much lesser compliance. But this was disproportionate to the shunt fraction, which was 0.5, which and the physiological basis that Gattinoni mentions in this paper is the lung perfusion regulation is something that is impaired in COVID lungs. So this is what he mentions. And there is a vascular issue. There is a hypoxic vasoconstriction that is leading to a big ventilator perfusion mismatch sort of a situation. and that is leading to hypoxia is what the hypothesis that is generated in this paper. And this is the graphical representation that compliance is good and the shunt fraction is very small, which is very disproportionate. So it's just a one page article, one page or two page article. So the conclusions the Gattinoni makes, or rather he just highlights that there is a possibility that when patients are putting increased work of breathing, the increase in intrathoracic negative pressure possibly could lead to self-inflicted lung injury. So this is a hypothesis that he makes from the observations because of the disproportionate compliance and the shunt fraction that is prevailing. And when you use high PEEP like we would conventionally use in an ARDS, where the recruitability of the lung is a questionable, so it can lead to, because you're giving high PEEP, so it has the deleterious effect of this may be manifested with hemodynamic impairment in the setting of myocardial dysfunction that is known to occur in these COVID patients with fluid retention. And when we go on to prone, where compliance is very good, but you're proning to circumvent the hypoxia, so the benefits may not be huge. So this is the conclusion. So I would say it is still hypothesis. So we need to derive observations from our Indian experience and see whether our Indian patients do manifest with this increased compliance. Because I got some reports from certain people who have treated ventilated patients in India saying compliance was good. So we need to make recordings of these compliance and see whether they are behaving differently to the conventional ARDS. So I'm sure this is a WhatsApp you've been seeing. So I would end my presentation with this to sum up. Somebody ate something in China and the entire world is washing. I'm sure this WhatsApp message you've been seeing. So thank you very much.